At this time, I would like to introduce you to our speaker. Dr. Lisa Gall is a clinical program manager at Stratus Health, family nurse practitioner, health IT leader, and certified PQRS specialist with over 30 years experience in nursing, administrative, provider, and health IT roles. After 18 years in nursing, Lisa graduated from Concordia University's Family Nurse Practitioner program. She practiced for 14 years in rural primary care, nursing home, urgent care, and emergency settings. She returned to the University of Minnesota to complete her Doctor of Nursing practice in 2010 and Health IT Leadership Certificate in 2011. She currently helps healthcare organizations and clinicians understand emerging healthcare policies such as CMS, meaningful use, PQRS, and quality payment programs. Lisa brings a clinician's perspective to help organizations understand how value-based care affects practice, how to operationalize policies in meaningful ways, and how to enhance practice using data and technology. Lisa is lead clinician for Lake Superior QIN in the CMS-funded Transforming Clinical Practice Initiative and sits on the CMS Technical Expert Panel for the Quality Measures Development Plan. She has published, taught, and presented on various health IT topics, and we are very lucky to have her present for us today. Lisa, I'll turn it over to you.
Hello, can you hear me okay?
Yep.
Okay, thank you, Kim, for that very kind introduction. I'm just so excited and happy to be here today presenting on the final and third session of the MACRA Quality Payment Program for CMS. The first session reviewed the overview, reviewed the whole program of Quality Payment Program. The second session addressed the MIPS payment, and today we're going to be talking more about the alternative payment models. And we'll be talking also about some resources. Oh, I'm going to move my screens here. I do work for Stratus Health. I am a clinical program manager. Stratus is a quality improvement organization, and the lead QIN, lead in the QIN involving Michigan, Minnesota, and Wisconsin. As I said today, we'll be talking about the overview, the key concepts of the Quality Payment Program's alternative payment models. I want to also thank the National Rural Health Resource Center for allowing me to present, and Stratus Health for participating as well. So the goals, objectives we'll go over today are the overview, reviewing medical home models, understanding how collaborating care across settings can improve quality and decrease costs. We'll talk about engaging clinicians and engaging patients, and what your hospital and clinic needs to know to begin transforming to value-based care, which you've already done in other ways. So just a brief overview of the next few slides. We'll talk about the Quality Payment Program and what exactly is involved with the Quality Payment Program. There are two tracks in the QPP, which is the merit-based incentive payment system or alternative payment models. And this diagram just shows that the two tracks or paths for an eligible clinician can be a MIPS path or an APM path, and that can vary throughout year to year or even within a year. So as you remember from path one, the merit-based incentive payment system is based on reporting to 4 categories or scoring on 4 categories. And 3 of those categories are reportable. Quality replaces PQRS and accounts for 60% of your total MIPS score. Your MIPS score is actually a 1 to 100 point scale score, and 60% of that comes from quality, 15% comes from improvement activities, which is a new category, and 25% comes from advancing care information, which is like meaningful use. The second track of the quality payment program is the alternative payment model and advanced alternative payment model path. So let me talk first about alternative payment models, what they are. They're a new way to compensate providers for care and services rendered to Medicare beneficiaries that promotes value and quality over volume by moving away from traditional Medicare fee-for-service structure. And the goal of advanced payment models is to reduce spending while improving patient care. And APMs are entities that can apply to a specific clinical condition, a care episode, or a population. And as you see in the diagram, advanced APMs are rather a subset of APMs, alternative payment models, where the advanced APM practices earn more for taking on some additional risk related to their patients' outcomes. And those eligible clinicians who are part of an APM and an advanced APM can earn incentive payments by improving patient care and taking on that additional risk. So this picture diagram shows the two paths on the right. It is the MIPS eligible clinicians with the 4 reportable categories. And if you're an eligible clinician who belongs to an organization that belongs to an advanced APM, you still need to meet some criteria that I will talk about. And if you don't meet that criteria individually, seeing a certain percentage under the advanced APM payment system, then you default to becoming a MIPS APM reporter, and instead of reporting under your advanced APM, you actually report under a MIPS score similar to MIPS eligible clinicians. I'm going to tell you that I'm going to be moving through much of this material rather at a quick speed, so I apologize for that in advance. We do have a lot of material to cover in this short time, so I'll be moving rather quickly. And if you have questions at the end, we'll hopefully have some time to answer those. And of course, you will have the webinar slides to review as well. So first, of the 3 types of alternative payment models in the quality payment program are the alternative payment models, and I'm just going to talk as an overview, and then we're going to talk further about the advanced APM and the MIPS APM reporting scores. So alternative payment models do offer opportunities to eligible clinicians not quite ready for advanced alternative payment models that have those higher risk areas. So you can belong to an APM that might not be a qualified advanced APM. The benefits of participating in an advanced payment model for qualifying professionals, and this is the advanced APMs, there are specific benefits from being in the APM. The focus is on quality and efficiency. There are no MIPS payment adjustments. Participants who are qualified participants can receive a 5% lump sum bonus and receive a higher physician fee schedule update starting in 2026. Those who are in an APM but non-qualifying based on the types of patients they see and bill for will get APM-specific benefits of being in that model. They may earn incentives based on their outcomes. They also focus on quality and efficiency. They do and can have MIPS payment adjustments, but there is a higher scoring available under a MIPS APM versus plain MIPS. And then you do have an a potential for exceptional performance bonus under the MIPS APM. So the alternative payment models as a whole are defined by the CMS by MACRA as a CMS Innovation Center model. Some of the examples are Medicare Shared Savings programs, demonstrations under the Healthcare Quality Demonstration Plan, and those demonstrations will be required by federal law. So the advanced alternative payment models must meet 3 criteria to be considered an advanced alternative payment model. First, they have to require participants to use a certified EHR technology, pay for covered services based on the quality measures comparable to those used in MIPS, and either be a medical home model expanded under CMS Innovation Center or bear more than a nominal amount of financial risk. So we'll talk about the first criterion. At least 50% of the clinicians in each APM entity is required to use certified EHR technology to document and communicate clinical care information with both their patients and other health professionals. And for the advanced APM Medicare Shared Savings Program, requires that clinicians report at the group level according to MIPS. The second criterion is to base payment on quality measures comparable to those used in the MIPS quality category. And these are evidence-based, reliable, and valid. And at least one of those quality measures must be an outcome measure available on the MIPS measures list. The third criteria for an advanced APM is either the advanced APM must be a medical home model or require participants to bear more than nominal amount of financial risk. I will explain these a little more in detail. First, I'm going to talk about the bearing nominal financial risk. So the bearing financial risk, the advanced APM must require the participants to do one of the following if their actual spending is greater than the expected spending, either withholding payments, reducing payments, or requiring direct payments back to CMS for Medicare Part B physician fee services. The total amount of risk that the advanced APM must meet is either 8% of the estimated total Medicare Parts A and B revenues, or 3% of the expected expenditures under the APM. These are the current advanced APMs that CMS allows to participate as an advanced APM. I will also say that Medicare does not expect a lot of eligible clinicians to be parts of advanced APMs for 2017. As the years goes on, that number may increase, but they're looking at less than a 5% across the nation being involved in advanced APMs and eligible to participate in advanced APMs. This list is also available on the qpp.cms.gov website. I'm going to back up and just explain that the Medicare Shared Savings Plan, Medicare MSSP, only the tracks 2 and 3 are eligible as advanced APMs. Track 1 is an advanced APM that will have special benefits under MIPS scoring. So the steps to earning a 5% advanced APM incentive payment in 2019, which can be fairly significant if you do see a lot of Medicare Part B services. So first you need to meet the thresholds of either 25% of payments received through the advanced APM or 20% of patients seen through the advanced APM. And that is of your patients who are billed to Medicare Part B. And then secondly, you must submit quality data required by your advanced APM in the 2017 performance year. So those eligible clinicians is ECs who do not meet those thresholds of 25% of payments or 20% of patients do need to submit data under MIPS to avoid the downward payment or negative payment adjustments. So let's talk a little about the qualifying APM participants or QPs, qualifying professionals. So you have eligible clinicians become qualifying professionals if they see 25% of the amount billed to Medicare Part B under the advanced APM or 20% of the patients they see in the advanced APM. And this must be a qualified advanced APM according to CMS and have a agreement with Medicare that they do qualify for that. So as years go on in 2017, these numbers are 25 and 20%, but as you see, the numbers will in 2019 will move up to 50% of payments and 35% of patients, and by 2022, the numbers will be even higher, 75% of payments and 50% of patients. So over time, the number and amount of Medicare billable services that are going through the advanced APM need to be higher and higher each year. And this is just a formula for calculating the payment and patient thresholds for qualifying professionals. There are basically two methods, the payment amount method and the patient count method. So you take your numbers, your dollars for Part B professional services to your attributed beneficiaries, which is really important. It's not just straight, but whatever is attributed to your advanced APM versus the total number of Part B professional services to your attribution eligible beneficiaries. And the same formula for attributed beneficiaries for the patient count method. So how do eligible clinicians become qualifying professionals? That is made at the advanced APM entity level. So if you have an advanced APM, the entity that bills is the advanced APM entity. And that matches up with the tax ID number. There are exceptions if there's someone who participates in multiple advanced APM entities, and none of those meet the qualifying professional threshold as a group, or if you're on an affiliated practitioner list just for QP determination, because there are no eligible clinicians on that list for the advanced APM. And they gave an example of that as gain sharers in the comprehensive care for joint replacement model. So CMS will actually calculate a threshold score for each advanced APM entity's payment amount and patient count based on Medicare Part B professional services and the APM's attributed beneficiaries. CMS will use the method that results in a more favorable determination of one of those two methods. So do you need to be a qualifying professional right away in January 1st of this year? No. You have 3 opportunities to be able, for your APM entity, to be able to add their qualifying professionals that meet those thresholds to their APM entity participant list. And those dates are March 31st, June 30th, and August 31st. So your eligible clinicians must be on the APM participation list on at least one of those days. If the APM eligible clinician does not qualify, then that particular clinician will need to report under the standard MIPS or APM MIPS. And you may have an APM entity who as a group qualifies, and they may have, if they have 100 practitioners, they may have 90 who are in the advanced APM, and they may have 10 who will need to report individually under MIPS APM. So the CMS has provided this, some clarification on how QPs are determined during the performance period, and they use claims data from a period during the year or 2 prior to the eligibility period. And if you meet the threshold, then eligible clinicians, additions to those clinicians can be added on those snapshot dates that I showed you earlier. So this just is a picture diagram of the advanced APM in the middle. And so the advanced APM is actually the advanced payment model. It's a payment model. The entity becomes the payment model used in a tax ID number with a bunch of NPIs under it. And then under that is all of the eligible clinicians. So you may have your advanced APM qualifying professionals, and then you may have some who are non-qualifying or partially qualifying professionals that may need to report under MIPS. So let's talk then about those professionals that are as part of an advanced APM, but they didn't meet the threshold. So then they become a MIPS APM, a MIPS eligible APM clinician. So what's the benefit of that? Is that certain, oh, I think I missed a spot here, sorry. Certain APMs include MIPS eligible clinicians as participants and hold their participants accountable for the cost and quality of care provided to Medicare beneficiaries. As you can see, under alternative payment models, you have MIPS APMs also. Before this was advanced APMs. So if that APM does not meet the criteria to be an advanced APM, they may qualify for being a MIPS APM, which gives them higher scoring status under MIPS. It also reduces the burden by streamlining the MIPS reporting and scoring method. And where the scoring standards are beneficial are under the improvement activities for participating in an APM, and it also focuses on goals and objectives of the APM entity. Under MIPS APMs, all eligible clinicians receive the same MIPS score, and it models APM-related performance as much as possible. So as you know, certain APMs include MIPS-eligible clinicians as participants and hold those participants accountable for both the cost and quality of care provided to Medicare beneficiaries. So this is the type of APM called a MIPS APM, and the CMS assigns scores to MIPS eligible clinicians in the improvement in activity performance category for participating in MIPS APMs. And most advanced APMs are also MIPS APMs. Not all advanced APMs are MIPS APMs, and I'll show you in a few slides down the road. And again, if they're not meeting the advanced APM threshold, then they report under MIPS. So the MIPS APM scoring standard applies if the APM entity is participating in the APM under agreement with CMS. They include one or more MIPS eligible clinicians on their participation list, and the APM bases payment incentives on performance, either at the APM entity or at the eligible clinician level for cost, utilization, and quality. Again, for MIPS APM eligibility, for the MIPS APM scoring standard, this is the same dates for being eligible or on an APM participation list, March 31st, June 30th, and August 31st of the performance period. So these are the MIPS APMs that qualify for the APM scoring standard this year. So we talked a little about the Medicare Shared Savings Program, ACOs. There's the Track 1 APM. Only the Tracks 2 and 3 are APM, MIPS APMs. The next generation ACO model, those in green are all advanced APMs whose participants may qualify for APM MIPS scoring if they don't meet the threshold. The CEC comprehensive ESRD care model, only the two-sided risk arrangement, and then the oncology care model, two-sided risk arrangement, and the CPC plus model also meets the criteria to be a medical home model. So let's talk about medical home models, which is described by CMS. A medical home or Medicaid medical home model is an APM or payment arrangement that is determined to have the following requirements. First, they have to have a primary care focus with the participants that include primary care practices or multi-specialty practices. That includes primary care physicians or practitioners and offer primary care services. The medical home model expanded under CMS Innovation Center Authority must meet at least 4 of these additional elements. And that can be planned coordination of care, chronic and preventive care, patient access and continuity of care, risk stratified care management, coordination of care across the medical neighborhood, patient and caregiver engagement, shared decision making, and or payment arrangements in addition to or substituting for fee-for-service payments. So they don't need to meet all of those, but 4 of those elements to be a medical home model. And late in November, or was it early mid-December, CMS added several medical home models to the APM, to their list of qualifying medical home models. And I know that the Minnesota medical home model was included on that list. I am not sure about other states on how their models are, and you might want to check with your state if you have a different type of model, if that qualifies. And the reason that it's important for medical home models, besides the continuity of care and quality of care and patient engagement involved in medical home models, is that you get a higher scoring under certain categories of MIPS. Back up here. So as I said, one of the key elements of a medical home model is to engage patients. And one of the key elements of the quality payment program and a CMS initiative is to engage patients. So CMS took a very broad approach to person and family engagement, putting in place policies, programs, and quality improvement plans. They've designed a lot of their benefits and payments regarding around patient and family engagement, and they're calling it actually person and family engagement. They're focusing on value and incentive payments. So then they are also engaging patients more and requiring, I shouldn't say requiring, but really encouraging organizations to engage patients in decision-making, care coordination, prevention, and treatment, and implementing a patient and family caregiver support. And really what happens is change happens when there's alignment across quality measures, quality improvement, policies, and oversight activities, and that's why the multifaceted approach from CMS. So CMS is really putting the best interests of its beneficiaries first, actively encouraging people to engage with their providers and empowering patients and advocates to communicate their preferences. They want to meaningfully include patients and advocates in policy discussions as well. So what CMS is doing regarding person and family engagement is looking at the values that is implementing these values. So they want organizations to do person-centered care. They recognize the importance of health literacy and its role in improved health outcomes. They want accountability for both patients and providers to take responsibility for outcomes of their actions, and respect, so mutual respect between individuals and providers. And of course, we all know we're engaged with our patients, but I think CMS is looking at a higher level engagement where actually patients are involved in decisions on quality measurement and outcomes, and what types of things patients really want and need in healthcare. And also, CMS has put together this cycle, I should say it's a schemata or concept design, how they promote informed decision-making on the top, and sorry if these were really hard for you to see, shared preferences and values on the right, co-creating goals, promoting patient and family engagement best practices, and encouraging engagement and self-management to improve healthcare experiences and healthcare outcomes. So engaging clinicians. So we've talked about engaging patients. Engaging clinicians might be, rather challenging. I want to speak a little to this, more from my heart, is that the triple aim of the National Quality Strategy is for better care, healthier people and communities, and affordable care. But a fourth aim, which is being recognized by healthcare leaders and clinicians around the U.S., addresses clinician and staff satisfaction. There's a real problem with workforce burnout, especially when a lot of these incentive programs got implemented, electronic health records, PQRS, e-prescribing, all of those things. And how can we engage clinicians and return the joy in physician and other providers' work, and the staff that work with them. There's a big problem with workforce burnout due to the multiple increased demands. And you can see those. I mean, these are the things that I've put together that are really, difficult to do in rural, especially small and rural settings. Excuse me. Excuse me for 1 minute. Can you hear me again?
Nope.
Okay. So all of these things, the EHR use and documentation, technology. This is a really tough one, especially in states that don't have a statewide health information exchange, or if you live in an area where patient portals are a big problem, either from geographically where you're at, or patients you serve aren't going to jump online real easily, or don't even have access to internet services. And then, of course, there's the quality reporting to those multiple mechanisms that I, just went through, PQRS, of course, value-based modifier you don't report to, but you get rated on. Meaningful use was all or nothing reporting. So a lot of those, and then there's HEDIS and, all the other quality things that you need to report to. So now we're bringing into changes in care delivery. How is care delivered in the healthcare setting? So they're talking, and not only CMS, but all organizations and payers and people who talk about healthcare quality talk about the PCMH model, primary care medical home model, team care, engaging your patient in processes. And there's much more increased transparency in the care that we provide. Things are available on the physician compare, hospital compare, and the like. There's even nursing home compare. And patients have more access to their records and want more access to their records. And surveys state that patients do want access to their records. And also, where errors happen in the healthcare in our nation is in transitions of care. And we really, the government has, and quality improvement organizations have really focused on increasing care coordination processes, between settings. And of course, we all know the problem with cost is that, our healthcare spending is going further up, and so we are implementing value-based care, which gives you more bang for your buck when you, purchase healthcare services. Just like when you go shopping, you want more bang for your buck. This is basically, the same thing. We can't all be, individual clinicians, professionals. We're paid on fee for service on the amount, and now we want to be able to get a value out of that. And also, the population management is becoming more of an caveat to how you provide care, remembering that it's an individual patient within the population. So you're looking on one side your patient, and on the other side the population you're serving. And this all requires a team approach. It's different than what we're used to and how we're used to providing care. It used to be, I'm the primary care provider in our small rural clinic, and I'd talk with my patient and we'd come up with a plan, and you can still do that, but with all these additional pieces in there, we really need the team to really coordinate the care well for our patients, to improve the quality and outcomes and their general overall health it's not a one-to-one anymore. It's multiple to one or multiple to maybe your patient and the family and caregiver. And that culture change really takes a lot of time and effort to implement, and does start with leadership. So as I alluded to, the physicians and other healthcare workers do not have the resources to meet the increased patient demands found in patient-centered medical homes. Family physicians were among the specialties with the highest rates of burnout, resulting in a loss of enthusiasm for work, feeling cynical, and a low sense of personal accomplishment. There's a lot of early retirement, alcohol use, and even suicidal ideation. Lower levels of clinician satisfaction can also lead to lower quality of patient care. So you really want to maintain a balance between the workforce satisfaction and the patient satisfaction. So not only are you, getting your patient satisfaction scores, you really should, be looking at how are your clinicians doing. And how do you do this? You really need to use teams to complete EHR documentation and prescription processing. For example, your medical assistants or nursing staff can help with chronic disease management and preventive care. Of course, they will need some adequate training and know what the guidelines are, and follow best practice guidelines or your internal guidelines that follow that. Secondly, you want to empower your physicians and other clinicians to lead that transformation. We don't want to do this to the providers. We want to have them leading this change in how we provide care. In order to do that, all clinicians need to work at the tops of their license. This is, particularly true among advanced practice RNs and physicians assistants, who can provide primary care in certain circumstances and refer to physicians when needed or in complex situations. And we really need to involve clinicians in the planning and problem solving and quality improvement efforts, all along the whole process. That will require some education and feedback. Get that feedback early and often. As with any major process of change, you want to, do iterative adjustments based on feedback. And then the quality, this really focuses on the quality improvement efforts. It should be meaningful and relevant to your practice. It's not just to meet the higher payment adjustments or non-payment adjustments, but it really needs to make most sense for your practice. The technology is there for clinicians and for IT to look at risks and finance to look at reimbursement. We can have dashboards developed and do point of care costs. If I have a patient who comes in to see me in our rural health clinic, asks me how much is it going to cost to get that mole removed, I have no clue. I'd have to do quite a bit of digging to know what exactly that cost would be for that patient who has let's say a $10,000 deductible. They want to know. I'd like to know as well as a provider, so I can give them a good feedback and make an informed choice on that with them. And then we should really be using analytics to identify those high-risk patients or populations and some predictive analysis on how we can prevent readmissions, for example. So we're going to talk a little, let's see, we're sitting at 12:42. I think we're sitting pretty good for time. Value-based care in small and rural settings, this is not new to you. Your rural critical access hospitals already do value-based care. I want to talk a little bit about how you can assess your value-based care capacities across categories. There is a value-based care readiness report that was developed by the National Rural Health Resource Center's Rural Health Values website. And it is an online tool that is available. The website is listed below, that you can sit down, but you want to do this as a team to complete how you are sitting today and do a current snapshot of where you are, what you're aware of for value-based care. It assesses your readiness for value-based care, and it helps you develop action plans. So the people you want at the table to do this in a group, in tandem, is your leadership, clinical, IT, quality, and finance representatives. And really, the take-home is that it's not how you score as much as becoming aware of the practice transformations that are required in the value-based healthcare system. Second thing you want to, for rural and small things, is to assess where you are for technology. Right now, in order to meet meaningful use under Medicaid and hospitals, you need 2014 certified EHR. Beginning in 2018, you will need 2015 certified EHR technology. What that will offer that 2014 does not is the public health reporting capabilities, accepting patient information into the EHR, accepting and requesting summaries of care, and more robust online patient access for education, as well as clinical reconciliation rather than just medication reconciliation. The second technology piece that is still looming and you know, as a carrot is health information exchange. If you have a state, if you live in a state that has a state supplied health information exchange, those states are doing very well with care coordination. And also the 2015 certified EHR technologies will allow patient portals and application program interfaces from patients that can bring their own electronic records in an API. But not all EHRs do accept API. You will need to check with your vendor. And I want to explain an application program interface is a set of protocols and tools for building application software. It's a defined method of communication between various software components. And it makes it easier to develop a computer program by providing all the building blocks which are put together by the programmer. You know, it could be a web-based system, an operating system, a database, or software, and it can take many forms. So the next thing you want to do to prepare is assessing care coordination partnership and your data needs. So what is your current state? What data do you exchange now and with whom? And a future state. What would you like to exchange and with whom? And you really want to look at, and this is for health information exchange, considering your community and regional partners, the referrals, all your community organizations like public health, behavioral health, long-term care, short stay facilities, assisted living, and subacute care. All these players have to do with continuity of care and are being pulled into the health information exchange and continuity of care quality improvement to have healthier outcomes for our patients and population. So the next steps for your hospitals in healthcare transformation, you as hospitals have pretty significant knowledge already and experience in a measure submission, value-based care, and reporting requirements. And this may be valuable for other I'm sorry. I think I jumped ahead here. No, I didn't. Okay. I guess it was the same. I thought I was on the wrong page because my printout looks a little different here. So you want to begin some long-term planning for community and population health management and really increase your care collaboration across all settings of care, and again, involve your clinicians early enough and invest in education and time for the long run. And there is increasing pressure on those receiving fee-for-service payments to move to alternative payment models. The competition is growing among alternative payment models, and it creates more opportunity, but also creates a little bit of tension. And also, it seems the trend is more of physician employment and or collaborative agreements between physicians and larger practices. And value-based care does affect hospitals. For example, post-acute care is really a focus for savings on preventing readmission. And there is a push towards registry and electronic reporting and data transparency. And I did mention the compare websites, the CMS websites. And then you should try to prepare for your 2015 certified EHR technology and check with your vendor on when that will be available. So this is a big list, but it's the key points, and really what you need to do is involve everyone. You need to involve your clinicians, your patients, your staff, and most importantly, it starts with leadership, you know, to really put a good plan in place. And I did talk with that plan about the assessment. You really need to do your environmental scan. How are you doing today? Where do you want to be in the future? And compared to value-based healthcare transformation. I'll talk a lot, but lastly, we have about 10 minutes left about relevant resources. I'm going to run through these very quickly. There is support for small and rural practices. MACRA has designated $20 million a year for 5 years to fund training and education for Medicare clinicians in individual small group practices of 15 or less. That is to be announced. What has been shown is that physicians in small practices who report their performance can do just as well as mid-sized practices can. So once that support is available to you, your organizations can help you select quality measures and health IT, train your clinicians, assist you in evaluating your options for joining advanced APMs, and making sure that your clinicians can focus on what's the most important, and that's the needs of the patient. The second resource is quality innovation networks, quality improvement organizations. There are 14 across the nation. The Lake Superior Quality Innovation Network serves 3 states, Michigan, Minnesota, and Wisconsin. We are the Lake Superior Quality Innovation Network. There are 13 others. There's an interactive map of QuinQuos available that you can go online to look in your area. There's also, I'm sure you've heard this, the Transforming Clinical Practice Initiative, which is funded by CMS to support more than 140,000 clinicians over the next 4 years. And their focus is in sharing, adapting, and developing their quality improvement strategies. There are a lot of benefits for the clinicians in becoming part of TCPI. There are not only the practice transformation networks, but there are learning and action networks, support and alignment networks, which involves professional organizations, for example, the American Association of family physicians, but basically your large organizations that are your professional organizations are part of the SAMs under the TCPI program. There is an Innovation Center learning system online that you can learn through your APM. So your APM, if you join one, has online education and strategies. And biggest place to find questions, answers to your questions are on the QPP website. Very interactive. It lists all your improvement activities, your quality measures, your advancing care information, and talks about advanced APMs and APMs. And you just, if you click through the pages just to learn a little bit about the QPP, about 80 to 90% of what you need to know is there. And if you look under the educational and resource, has additional information, including the quality benchmarking is on that site. These are just several of the additional resources, the CMS resources. I'll just quickly page through these so that we have some time for question and answer. I do want to have people ask if you are involved in any of the following programs. And as you answer that, I'll hand it back over to Kim. Thank you so much.
Great. Thank you so much, Lisa. I'm just going to give people a minute here to complete this poll, and then we will go to questions. All right. Sarah has a question, Lisa. If there is a mixture of APM, QPs, and non-qualifying, you could report all as non-QP to be consistent across the organization, correct?
I'm going to have you repeat that question. If there's a what? A mixture of what?
If there's a mixture of APM, QPs, and non-qualifying, could you report all of them as non-QP to be consistent across the organization?
I would recommend not, because your payment incentives are going to be greater with your advanced APM. And if you're a large, if this is a fairly large organization, it really depends on the size. I think the qualifying is, why would you join an advanced APM and not take the benefits of that advanced APM if you have qualifying professionals? So I would report as many as you can under the advanced APM side. And then those who are not meeting the thresholds would report under MIPS APM. Does that answer the question?
Does each provider have to meet qualifications to become QP, even if they are part of the advanced APM?
Yes, and I did clarify that with CMS in 2 ways this week, because it was in some of the CMS slides, it's very unclear when you look through the websites on that. And so we did get clarification from CMS from 2 different sources that said, yes, your APM entity can use your list of professionals, but if you have one EC in there who did not meet those thresholds, then they need to report under MIPS.
Great. Lisa, how many vendors have 2015 CERT available?
You know, I looked at that yesterday online. It's the ONC certification, the Chapel website. I always call it CHPL product list. And there were, I noticed that Epic was in there. I noticed that Allscript was in there. But you go on the website and you double check. That can change from day to day, but I believe that I can't remember right offhand how many, but there were a number. I want to say in the 40s.